Advanced clinical practice embodies the ability to manage complete clinical care in partnership with patients and carers. It includes the analysis and synthesis of complex problems across a range of settings, enabling innovative solutions to enhance patient experience and improve outcomes. Health Education England 2017. Bryant Lukosis et al. 2004 suggests that advanced nursing practice is fundamentally about the level at which a nurse functions, that is, a multidimensional and involves a plethora of skills within their scope of practice. This suggests that advanced practice nursing encompasses a range of nursing roles in various clinical and non-clinical settings. Many barriers to effective advanced nursing practice could therefore be avoided by improving planning, better understanding of environmental factors, and increased resources. Advanced practice nursing enables autonomous clinical leadership and is different from typical management roles, so is appealing alternative for nurses who want to progress in leadership and continue to practice clinically. AMP's identity will strengthen and the role will become central to the delivery of holistic, patient-focused and high-quality care and to the achievement of organisational targets such as reducing hospital admissions and length of stay. In a diverse society, caring includes recognition of individual differences in the way in which those with protected characteristics may be disadvantaged. Wiseman 1994 defines that clinical and professional leaders and advanced practitioners hold positions of influence as role models for less experienced professionals and as experts in their field. Their actions can have a profound effect on patient care and treatment, and as Thompson and McMurrow in 2021 highlight, not only clinically but also in the ways in which people are treated in the UK. In the UK, adoption of advanced nurse practitioners has been slow. There remains a lack of literature that details the overall contribution of advanced nurse practitioners in mental health towards health and social care outcome. Fung et al. In Hong Kong did identify that they can make a difference to mental health service well-being. However, that their multifaceted roles need to demonstrate that they are also providing cost-effective services. This remains a challenge for any mental health nurse. The key aspect of advanced practice is leadership, and within this role model, modelling skills and behaviour, it has been proven that the use of advanced practitioners in clinical settings improves patient care and increases the outcome for all. We know that by role modelling behaviour, more junior staff are able to learn and understand and develop based on the behaviour of those in senior roles. It is important that advanced practice nurses use evidence-based research in order to base their practice and develop services. For the context of this presentation, clarity around terminology is discussed here. Advanced nurse practitioner is used to cover all advanced practice roles, e.g. advanced clinical practitioner, advanced practice nurse. Perinatal care is the care provided during pregnancy, before, during and after birth, including care for the baby during the first year. Trans is someone whose gender identity does not match or sit comfortably with their gender assigned at birth. This can include non-binary people, though not every non-binary person considers themselves to be trans. Misgender is referring to someone using incorrect gendered terms, using incorrect pronouns, or treating them as an incorrect gender. Dysphoria is a feeling of discomfort or distress from the incorrect perception of a trans or non-binary person's gender. This can vary in intensity and can lead to significant distress. Cis, someone whose gender identity matches with their gender assigned at birth. Non-binary, people whose gender is not male or female may use different terms to describe themselves, with non-binary being one of the most common. In this presentation, I'm using trans in the broadest sense to include non-binary people and those questioning and exploring their gender identity. Trans people can give birth. The Government Equalities Office in 2018 estimated that trans people make up 200 to 500,000 people in the UK. It can be considered a small number, yet if you think about it made up of individuals, it can be considered large. Unfortunately, we have no way of knowing how many of these are parents, let alone how many have been or plan to be pregnant. Demographic data has not been recently collected in any perinatal services, and Chrisman and Strassman in 2020 discussed that is due to the assumption that all patients are women. Perinatal services have long been focused on women and babies. Language use is focused around their mother, and Jennings, Gut and Whitaker discussed that almost all settings use gendered words regarding mothers and infants. Goldberg, Ross and Manley and Moyer discussed that even amongst trans people there are individual differences, wants and needs regardless of gender identity, and that pregnancy itself can cause a shift in how they identify. Pregnancy can trigger gender dysmorphia, and this can be a familiar dysmorphia or linked to specific areas like the hips and chest, or a totally new disconcerting kind. Equally, some birthing trans people feel totally at home in their bodies during pregnancy and might feel like the whole process empowers them. Chrisman and Strassman discussed the need for trans people on testosterone hormone therapy to stop taking it if they want to conceive, carry and give birth. Testosterone can be harmful to the fetus. Stopping testosterone is voluntary, and the desire to come off it to be a parent is a strong positive motivation. But the reality of this may still be psychologically rough, and it's vital that prospective parents are able to express negative feelings without judgment and have access to the appropriate mental health support. The UK's largest study of trans individuals in the UK determined that amongst transgender people, 88% of respondents showed symptoms of depression and 75% of anxiety, compared with 20% of people in the UK, as discussed by McGlynn et al. In 2020. The Maternal Mental Health Alliance indicate that as many as 1 in 5 women experience mental health issues after giving birth. This means that the mental health of trans people who have given birth must be a priority on a national level, as we know that there is a higher incidence of mental health issues in those that have given birth with pre-existing mental health conditions. Strassman et al. In 2019 discussed a case in America where a man arrived at the hospital with severe abdominal pains. Despite stating that he was born a female, care was not taken to check whether he was pregnant, and the issue ended in a stillbirth. Dr. Daphne Strassman of the University of Michigan states that what happened to this particular individual is an example of what happens to transgender people interacting within the healthcare system, and it is important that we identify this. Data from the Improving Trans and Non-Binary People's Experience of Maternity Service items has been discussed and compared to women in the Care Quality Commission's maternity services sample. We can see a significant inequality of experience, with trans and non-binary birth parents reporting poorer experiences in every question. It is the biggest study of its kind. 30% of those asked did not access healthcare, compared to 2.5% of women. 41% believed that they were spoken to with respect. 28% believed they were not treated with dignity, compared to 2% of women in a similar study. And 100% of those interviewed concealed their gender. The Items Project is a co-produced research project running from September 2020 to April 2021 and was commissioned by the Health and Wellbeing Alliance. The project was developed as a partnership with trans and non-binary birth parents, midwives, obstetricians and other clinicians. As a co-produced project, all voices were seen as equal. The Items Project was a mixed method study which collected primarily quantitative data through a survey and collected qualitative data through semi-structured interviews, receiving 121 eligible responses and 4 interviews. This made it one of the largest studies on trans pregnancy and the largest outside of America, where Morrison et al. In 2021 was larger. This adds to the growing evidence that there are a number of trans and non-binary people who become pregnant, and that this number appears to be increasing. Only 4 structured interviews take place, so data needs to be viewed with the low number of participants in mind. Research into minority areas is always going to be a challenge, as there will never be vast numbers, and considerable more research is required to understand the challenge of trans people in perinatal services. The omission of words in services such as woman or mother in favour of gender-inclusive or gender-neutral terminology can be a tendency to signal the clinician's acknowledgement of a minority group. When Brighton and Sussex Hospital launched their guide to gender-inclusive language in perinatal services, the document came under significant public scrutiny in the UK. Despite the strategy of trying to use gender-neutral and female language, this was discussed in the House of Lords, and Lord Hunt asked, do we really want to see demeaning terms such as menstruators and individuals with the cervix used in our systems? It is not unreasonable to expect that some women may feel debased by terms like menstruators, and clinicians have the same obligation to them to not use language that deeply offends. When introducing their rationale for gender-neutral language, Ross and Solinger noted that the danger that excising the word woman in order to include transgender persons in our reproductive justice analysis can have the effect of effacing the particular lived experience of women. If the aim is to maximise respect for every person's sense of self, it must follow that female patients who understand themselves as women cannot be expected to go along silently with language in which they do not exist. Arguably, discussions about gender-neutral terminology focus mainly on alteration of female-specific language rather than amending male-associated words. The Health Services Executive removed the word woman from their cervical cancer screening information, but similar examples such as Prostate Cancer UK continues to refer to men on their information page. Perhaps if simpler words are routinely to be used, then the reasons for this being used more in female health may be useful to examine. Further consideration is the intended audience of writing. Jargon-free communication is seen to be best, and simple words rather than convoluted phrases are known to be clearer. However, barriers to understanding phrases from those with differing socioeconomic, cultural, education backgrounds or limited knowledge, such as people with a cervix, must be considered when changing the language. Gender-inclusive phrases must not be viewed as a one-size-fits-all for transgender people. There are 60 terms and to describe aspects of gender, some of which have different meanings depending on the individual using those words. Transgender people themselves are diverse in identities, expressions and opinions, and it is important that all those considerations are taken into account. On a micro level, I encountered a trans male George referred into the mental health liaison team for the emergency department. He was 6 weeks postpartum and attended with his baby and partner. He had been to see his GP as his partner and himself were concerned that he was suffering from postpartum depression. The GP suggested he attend a dad's group and discharged him. George felt rejected and unheard. This caused trauma and upset, and he attended the emergency department where he was seen in a private room with his partner and his baby. I was able to ask what pronouns he wished to use and which terms he wished to use in relation to his parentings, and he had not been asked these questions before. I then carried out a postnatal depression questionnaire and Edinburgh postnatal depression score to determine risk factors and referred to the perinatal team, open to all women and trans males and non-binary people who have given birth. The referral was accepted and appropriate support was given. Other practitioners in the team felt empowered, having seen me ask questions that they stated they would not have felt confident to ask had they not seen it role modelling, which is part of the role of the advanced practitioner. Recommendations from the NHS England and NHS Improvement Plan are to continue to use inclusive language, individualised care plans to use inclusive language for all women, cis women, trans males, and anyone who identifies in a different way. These should be proactive conclusion, showing that birthing parents need to be able to access the care and understand that they are welcome. Personalised care for trans and non-binary people as well as cis people should be focused around the individual, and the principle that maternity care should be personalised and safe is central to the Betterverse vision from the NHS England in 2021. Existing guidance continues to look at individuals and to centre their care around them. Trauma-informed care should be considered as trans and non-binary people are more likely to experience trauma compared to cisgender people, as according to the Government Equalities Office in 2018. Services should proactively discuss taking a trauma-informed approach with trans service users and explain that this support is available. Training needs to be given to every midwife and other clinicians involved in perinatal care to be supported to deliver gender-inclusive care. This means investing in training as a priority delivered by trans people, organisations or individuals. IT systems for perinatal service should be designed to collect service users' gender identity and whether they are trans. These IT systems should prompt healthcare professionals to ask the right questions in order to personalise their care. In addition to these, demographic monitoring should take place so that we can understand and benchmark perinatal experiences and health outcomes of trans people compared to the general population. On a personal level, I will continue to research and discuss lived experience with those trans people who give birth. It is important to continue to role model behaviour, asking questions in order to bring about inclusive, personalised practice. I will consider all groups and continue to read the expert research and advice, and I will continue to remain open to challenge and change from others to develop my practice. References I have used in creating this presentation can be seen here should you wish to explore the subject in greater detail. Thank you for listening.